Today I'm going to talk about clinical trial on Tarlatamab in small cell lung cancer after the use of platinum-based therapy. Small cell lung cancer is an aggressive lung cancer subtype with the neuroendocrine differentiation, which is diagnosed in more than 150,000 people worldwide in each year. 3-year survival rate for the patient with extensive stage is less than 6%, usually 5%. And the available therapies are very much limited for the patient who relapsed. So most patients, the first line of therapy is platinum-based chemotherapy called etoposide. And there are certain PD-1, PD-L1 inhibitor therapies also available. But the median overall survival rate remains very less, which is approximately 12 months. Then topotecan is the most widely used second-line therapy, which is globally used, but it also associated with side effects and limited cytotoxicities. There are other chemotherapies, lurbinectedin and then amrubicin, which is approved in certain countries, not in all the countries, as a second-line therapy. But again, there is efficacy is very limited in these chemotherapies. Both of these chemotherapies have shown limited benefit with median survival rate only 7.5 to 9.3 months and also associated with hematological toxic effects. So far, no agent is specifically approved for third-line treatment in relapsed small cell lung cancer. Tarlatamab is a bispecific DLL3 directed T-cell engager immunotherapy, which recently got an accelerated approval for the treatment of patients with previously treated small cell lung cancers with either platinum-based therapies or with chemotherapies. So this bispecific T-cell engager, it binds to DLL3 in tumor cells and then CD3 on the T cells. So DLL3 is a member of Notch ligand family, which is normally do not express in normal healthy tissues. Only during embryonic development it expresses. It is an oncogenic protein which aberrantly expressed in several tumors, particularly in small cell lung cancer. So when mechanistically what happens when DLL3 binds to Notch receptor on the cell membrane, the Notch 1 is relocated to the Golgi apparatus and it becomes inactivated. So as a result, there is a downregulation of Notch ligands there, like HES1 and HEY1, which promote the development of small cell lung cancer. On the other hand, it is documented that because of the expression of DLL3, there is inter and intratumoral heterogeneity also available in these tumors. So here we can see when DLL3 is overexpressed, the Notch expression is low.
आप क्या बोल रहे हैं, फिर से बोलिए.
Platelets down है, तो उनका मैं pigtail नहीं लगा.
Will I continue? Hello? Am I audible?
Yes, you are audible. Please continue.
Okay. So there is here we can see there is tumor heterogeneity because of the DLL3 expression. So these days DLL3 targeted therapies are made significant progress in multiple cancer types. So these bispecific T-cell engagers are a new class of immunotherapeutic molecules which intend to treat the cancers. So here they are they have two kinds of variable region. One binds to the on T cells, particularly CD3, and then the other side binds to the tumor specific antigens, and as a result they do cell death in tumor cells. So in this clinical trial, it is a randomized open label phase 3 study where they've compared standard of care therapy with the Tarlatamab in the small cell lung cancers after the platinum based first therapies being given to the patients. So in this multinational phase 3 open label trial, they've compared the 3 different kind of chemotherapies. And then they found out that they've compared the efficacy and safety of Tarlatamab in compared to the standard of care treatment. So the main objective of the study is the primary endpoint was the overall survival, and the secondary endpoint was the investigator associated progression-free survival. So the study was that here in this study, they have presented only interim results, which they did up to January 2025. So in this study, they've 680 total of 688 patients were assessed out of in 166 sites in 30 different countries. So out of these 688 patients, 509 were randomly enrolled for this Tarlatamab versus standard of care therapy. So these patients were divided into 1:1 ratios to give Tarlatamab or other chemotherapy. So lurbinectedin was given or topotecan was given in countries like in the US, Canada, Australia, Singapore, and Korea. Amrubicin was given in Japan, and topotecan was given countries other than Japan and China. The stratification factors included for the study was previous exposure to checkpoint inhibitors like PD-1, PD-L1 therapies. The chemotherapy survival was lesser than or greater than 90 or 180 days or greater than 180 days. Presence of brain metastasis and intended chemotherapy, either topotecan, amrubicin, or lurbinectedin. So this is how they've selected the patient. The total of 688, as I mentioned before, 688 patients were assessed. Out of they've taken 509 patients. They were randomly divided into 2 groups, and then accordingly therapies were provided. So this is the demography of the patients. So the total number of male were total 182, and then female 72. This is the how they have divided into different ethnic group like Asians, whites. In whites, white also they have divided Hispanic or Latino, non-Hispanic and Latino. And then ECOG performance was 0 to 1, then smoking history, and then on the basis of whether they have given PD-1, PD-L1 inhibitor therapy, or this is the chemotherapy-free survival days. This is brain metastasis and whether liver metastasis, and even on the basis of DLL3 expression also. So this is the study design where Tarlatamab and chemotherapy was given. So this is the for Tarlatamab, this in cycle 1, they started with 1 mg per day, then 10 mg on the 8th day and the 15 days, and after that 10 mg every 2 weeks. This similarly chemotherapy was provided according to the country divided. So this is, as I have already mentioned, stratification factors, prior PD-1, PD-L1 therapies, chemotherapies, and then metastasis or the presence of DLL3 expression. This was the primary endpoint, overall survival. The key secondary response, duration of response, disease-free control, and safety and tolerability. So this pre and post infusion medications were dexamethasone administered before 1 hour before the cycle 1, and day 1 and 8. This is the for Tarlatamab they've given at day 1 and day 8 intravenous followed by cycle 1 of day 1 of Tarlatamab in day 1 and day 8. And then this is how they monitor initially for 48 days following the first 2 Tarlatamab infusions. After that, 6 and 8 hours. And then Tarlatamab was administered at 60-minute IV infusions. This is the protocol for chemotherapy in different countries. So, in all 509 patients who received Tarlatamab and chemotherapy, the treatment with Tarlatamab resulted in significantly longer overall survival than the chemotherapy, which was 8.3 months. Tarlatamab treatment had significant benefit in respect with respect to dyspnea and cough as compared to the chemotherapy. The incidence of adverse case also like grade 3 or higher was lower in Tarlatamab treated patient comparative to the chemotherapy, which was 54 or 80%, and the incidence of adverse event resulting in treatment were only 5% versus 12%. Rate in case of Tarlatamab in 6 months we can see there is 76% survival rate compared to the chemotherapy, which is 62%, and in 12 months we can see this is 53%, and in chemotherapy treated patient it is only 37%. Stratified hazard ratio is also less than 1. This is estimated RMST for progression-free survival at 12 months. So here also we can see in 6 months in case of Tarlatamab, this is 31%, and in chemotherapy it is only 23%. In case and after 12 months this is 20%, and in chemotherapy this is only 4%. So this is overall survival according to the number of the patients they've given in detail. So in confirmed complete response is in 3 patients, but in chemotherapy there is no complete response. Confirmed partial response in 86%. Stable disease was found in 84% of the 84 patients, total 33%. Then progressive disease in 56, like 20% of the patient. And there is objective response. Here we can see this is 35 in 35. Here it is only in 20 patients. And then risk ratio also, that is only 1.73%. Duration of response in months, we can see that here in case of Tarlatamab this is 6.9 months. Here this is only 5.5 months. And then this is if we calculate 25 percentile and 75%, there this is 3.8, and this is only 3%. Then there is duration of response at 6 months. Here it is in 56%. Here is only 29%, and at 12 months here it is in 41%. There 41. There is in 30. So here we can conclude that Tarlatamab has showing better response rate in patient in comparison to all different chemotherapy regimes. This is patient-reported outcomes also better in Tarlatamab in comparison to the chemotherapy. Here we can see all the scores are better in Tarlatamab in compared to the chemotherapy group. So here we conclude that Tarlatamab led longer overall survival than chemotherapy in patient with small cell lung cancer. So it can be used for as a second-line treatment in patient after the relapse of platinum-based chemotherapy.